Dr. Amrit, welcoming you to the diabetic retinopathy series. Today we are studying the importance of optical coherence tomography in diabetic macular edema. So in this video, we are studying about the importance of OCT as an ancillary treatment in diabetic macular edema, the various OCT patterns of diabetic macular edema, and the important biomarkers in diabetic macular edema which are seen on OCT, which will decide the prognosis of a patient and its response to the treatment. So without any delay, let's get started. OCT is basically an ancillary procedure in the diagnosis and treatment of the DME, that is diabetic macular edema. There are basically three basic structural changes that we see on an OCT, which basically is a subretinal fluid or an intraretinal fluid that leads to formation of cystoid macular edema or various other types of macular edema, and finally we have the retinal swelling. The type of protocol that we do on OCT to detect the diabetic macular edema is basically the macular scan, which are volume scans of the macula. And the anatomical distribution of DME can actually be monitored over time, especially where exactly the fluid is present and what is the relationship of the fluid to the retina that can be found in the OCT. So OCT is basically a very sensitive method for also objective evaluation of the vitreomacular interface abnormalities. As I told you, if we have the vitreous and then we have the retina behind the vitreous, so the junction of the vitreous and retina can also have a lot of abnormalities which can actually give rise to diabetic macular edema, and such abnormalities could be a vitreomacular adhesion, vitreomacular traction, and epiretinal membrane, which sometimes might be difficult to observe ophthalmoscopically, and therefore when we resort to OCT, visualizing these vitreomacular interface abnormality is quite easy on OCT. Now, as you can see in this picture, you can see a membrane over here which is extending and causing a macular hole formation, and similarly over here you can see this focal tractional areas leading to elevation of the retina and this epiretinal membrane. So such vitreomacular adhesion, vitreomacular interface abnormalities are better detected on OCT. Now, in my previous video on classification of diabetic macular edema, I told you how diabetic macular edema is classified according to the International Council of Ophthalmology as no DME, non-central involving DME, and central involving DME. In the non-central involving DME, the central subfield zone that is about 1 mm in diameter is not involved. And in central involving DME, the retinal thickening in the macula involves a central subfield zone that is about 1 millimeter in diameter. So as you can see, and this is what I explained in my previous video as well, that you can see the first picture is of the non-center involving DME and the second picture is of the center involving DME. So such EDTRS circle you can actually get on a macular scan on an OCT, which can help you classify DME into non-central and center involving, and specific documentation can be done using the OCT. Now, similarly, the DRCR net, this is also something which I mentioned in my previous video, it gives you the eligibility threshold per machine for treatment in a patient who is suffering with diabetic macular edema. So basically, if you consider Zeiss Cirrus and Zeiss Stratus OCT, the cutoff values are about 305 micrometers for men and 290 micrometer for women in Zeiss Cirrus, and in Zeiss Stratus OCT it is about 250 micrometers for both men and women, and the threshold values for Spectralis Heidelberg are a little bit higher. They are about 320 micrometers for men and 305 micrometers for women. So this is the circle where you're going to see the readings, and actually that is the point which represent the CST, that is central subfield thickness, and based on this thickness value you will decide whether to treat or not treat the patient. Now coming to the OCT classification or various patterns that we see of diabetic macular edema on OCT. So the diabetic macular edema could be a sponge-like retinal thickening which is called spongiform edema, or it could be cystoid macular edema which will have cyst. It could be in the form of subfoveal serous retinal detachment. It could be in the form of foveal tractional retinal detachment, or there could be a taut posterior hyaloid membrane. So these are the 5 patterns of DME that you see on OCT. So what is meant by the spongiform edema? So just have a look at these two pictures. In both the pictures, you can see that the retinal thickness is more compared to the normal retina. If you see, this thickness is more. However, there are not many cysts which are present. So there's a diffuse thickening of the retina, and such diffuse thickening of retina which occurs in diabetic patients is referred to as the spongiform edema. So important thing about spongiform edema is that there is a diffuse thickening and there are no cysts which are present within the retina. Coming to cystoid macular edema. In cystoid macular edema, as the name suggests, there will be presence of various cystic spaces within the retina. So you can look over here. There are lots of these empty spaces, and these are nothing but they are the cysts, and such as edema in diabetic is called cystoid macular edema. Now at this point, I would also like to tell you that the presence of cystoid macular edema is not specific to diabetes. It can present in various other conditions, various other retinal disorders as well. Now, the third type of diabetic macular edema is the serous retinal detachment type. Now, what happens in the serous retinal detachment type is, number one is, what is meant by retinal detachment? So, basically, whenever the neurosensory retina gets detached from the underlying RPE, that is retinal pigment epithelium, that is called the retinal detachment. And serous means that here we have the serous fluid accumulation. So this is called neurosensory detachment type or serous retinal detachment type of diabetic macular edema. So there is intraretinal fluid, and along with that thickening of retina, we also have a retinal detachment underlying in that retina. So this is the third type of DME. Now, the fourth pattern that you can see is a tractional type of DME. So, in the tractional type of DME, as the name suggests, there is a problem with the vitreous macular interface. As you can see over here, there are these membranes which are actually causing a pull on the macula, and because of that pull, the macula is being pulled forward, and we have this space which is created, and that space subsequently gets filled up with fluid, and we get diabetic macular edema. So, such a macular edema in which we have fibrous traction bands pulling over the macula is called the tractional type of diabetic macular edema. Then we have the taut posterior hyaloid which can be seen. So hyaloid is nothing but it's a posterior part of the vitreous. So exactly where the vitreous will actually join with the retina, that part is called the hyaloid. So sometimes the hyaloid itself will get thickened and it will be very tightly stretching over the retina, and that can cause traction, and that is called the taut posterior hyaloid in a patient with diabetic retinopathy seen in OCT. Now, sometimes you might not have the exact demarcation of various patterns on OCT. You might actually have a mixture of all these OCT patterns. So that type of DME is called a mixed type of DME. So as you can see in this picture, you actually have the cystoid spaces. So this is cystoid macular edema. Along with that, you also have the serous retinal detachment over here. So this is a serous retinal detachment with cystoid spaces. And you also have some part of traction component, although not very significant in this case. So you do have a posterior hyaloid membrane which is seen here. So such a kind of diabetic macular edema in which various components can be seen, various patterns can be seen, is called a mixed type of diabetic macular edema. Now the question is, why are we studying the various patterns of diabetic macular edema on OCT? The reason is that the answer is that they have different responses to various treatments. So when we talk about the spongiform type of diabetic macular edema, it has quite a good response to the anti-VEGF treatment. Whereas when you talk about the cystoid type of macular edema, that is cystoid macular edema, it will have good response to the steroids. So here I'm talking about the intravitreal injections that we give to the patient who is suffering with diabetic macular edema. So what happens is, for the spongiform type, it means that the patient will respond better or will have a good result with the intravitreal anti-VEGF agents. And when they have cystoid macular edema, it is advisable that the patient receives intravitreal steroids like triamcinolone. Whereas if a patient has vitreomacular traction, that means if the patient has DME which is having a tractional component or the tractional DME as we have seen, that person will actually respond to surgery. So for such people, anti-VEGF and steroids might not work. You might actually have to proceed with the surgery. Coming to the OCT biomarkers in diabetic retinopathy. Now, these biomarkers are nothing but there are various certain patterns that you see on, or certain markers that you see on OCT of a patient suffering from diabetic macular edema, which is going to predict the response to treatment and which is going to tell you exactly how the patient is going to respond to treatment, and it can help you to explain the prognosis as well to the patient. So what are these biomarkers, and how many of them are actually present? So the biomarkers that we see in OCT for a patient with diabetic macular edema, number one is the central subfield thickness. And I already explained to you what is meant by this central subfield thickness. Second is the drill, that is disorganization of the inner retinal layers. Then we have the disrupted external limiting membrane, disrupted ellipsoid zone. Then we have hyperreflective foci and dots, loss of parallelism, and the choroidal thickness. So these are the various biomarkers that you see on OCT, and let us review them one at a time. So the first one is the central subfield thickness. As I already told you, on a macular cube or a macular thickness map, you get or a macular scan, you have this EDTRS type of circle that you get, and that the inner 1 mm circular part of the EDTRS circle actually tells you about the central subfield thickness. So that central subfield thickness has a very modest correlation between the CST and visual acuity. So what I mean to say is that sometimes it need not be that if the patient is having more thickness in the central 1 mm circle, it means poor visual acuity. So there has not been very good correlation between CST and visual acuity. So it is only an anatomical surrogate to detect and monitor DME, and it is not a very accurate predictor for the best corrected visual acuity that the person will receive after treatment. So if one point I want you to remember about CST is that it has only modest correlation, not a very good correlation, because for example, some patients might have a very a good improvement in CST after an anti-VEGF treatment, but still land up with poor visual acuity. And the reason is that they will have problems in the ellipsoid zone or the photoreceptor atrophy. So all of that might be contributing to poor vision. However, your CST might come back to normal. CST might decrease in the thickness. So there is not a good, very good correlation between the CST and the visual acuity. So it's not a very good biomarker. The second biomarker is the drill, that is disorganization of the inner retinal layers. So when I talk about the inner retinal layers, I mean to say it is the ganglion cell layers, the inner nuclear layer, the outer plexiform layer, and the outer nuclear layer. Now, if you're not very sure about the layers of retina, I would advise you to clarify clear your basics first by reviewing my video on the layers of retina. So in drill, what happens is there is disruption of the demarcating interface lines between these cell layers. Okay, and the importance of having drill is that the eyes which are suffering with drills will have a worse baseline and final visual acuity despite your giving them anti-VEGF injections. So let us try to understand what is meant by this drill. So if you consider this to be our macula, you have to take a zone of 1 mm around that macula, and then just try to trace those inner retinal layers. Now in my video on macular anatomy of the normal macular anatomy on OCT, I have told you how can you differentiate the different layers of retina on OCT. So now in this picture, you can see over here we have these different layers. So on the right side of the image, you can actually see the layers of the retina. But if you compare it to this side of the image, you can see certain cystic spaces. However, the layers, the demarcation lines between the different layers, whether it's ganglion cell layer, the inner nuclear and the outer plexiform layers, all that demarcation is only present till here. When you enter this 1 mm zone, all the demarcation is gone, and that is known as the disorganized retinal layers. Okay, so that's called disorganization of the inner retinal layers or the drill, and such a patient will have poor response to the anti-VEGF. So that's very, very important. So drill is actually a very good biomarker. For example, if you see this picture, This patient actually does not have any edema. The edema has got resolved, and you can see that the layers are very well demarcated, and therefore the person has good vision. Now in the second picture over here, you can see the person is actually having edema. So you can see the inner retinal layers are actually pushed up, and you have certain hyperreflective areas over here which are causing the back shadowing, and there's probably fluid present over here. But a very important point that you see over here is that despite having such a great central subfield thickening of the retina, despite having all this fluid over here, the patient is actually having good vision. Why? Because the inner retinal layers are still showing some demarcation. Okay, so there is no drill present, and therefore the patient has good vision. Now coming to another third picture over here, you can see the retina has been, the edema has been resolved, and here the patient, you can see look at here, there are no demarcation line, and therefore the patient has poor vision because of the presence of drill. Now similarly here also the patient has edema, there are cystic spaces. Cystic spaces will distort your demarcation lines, and therefore the patient will have drill and therefore poor vision. So this is a video which is present on the channel about the macular anatomy on OCT, and all of you are advised to visit that video. Now coming to the next biomarker. The next biomarker is disrupted external limiting membrane. I'm so sorry for this. So it's a disrupted external limiting membrane. Now the external limiting membrane is actually present between the Muller cells and the photoreceptors. Now on my video on the anatomy of retina, I told you about how the external limiting membrane is actually formed, and on the OCT in the 4 hyperreflective layers which are present in the outer layers of the retina, the innermost one is the external limiting membrane that you see over here, this faint line, that's the external limiting membrane. Okay, so that faint line sometimes might get disrupted, and that is called disruption of the external limiting membrane, which is a very important biomarker. Okay, so now if you see this is a photoreceptor, this is the cell body of the photoreceptor, and this is the inner segment, and this is the outer segment. Now the outer segment is going to sit on the RPE, as I told you in my video on the anatomy, and also on the normal anatomy on OCT. And the external limiting membrane is actually formed by these foot processes of these cells. And what are these cells? These cells are the Muller cells. Okay, so at one end on the inner sides they are forming the internal limiting membrane, and on the outer side they are forming this external limiting membrane between the cell bodies and the inner segments of the rods and cones. So if you actually see the OCT imaging on the outer retinal layer, you can see we have the external limiting membrane. Outside to the external limiting membrane, we have the ellipsoid zone. Now, what is this ellipsoid zone? Ellipsoid zone actually is the junction between the inner segment and the outer segment, okay, somewhere here. And it was previously called the IS-OS junction, but now the terminology has changed and it is called the ellipsoid zone. Then we have outer to the ellipsoid zone, we have the interdigitation zone over here, and this interdigitation zone is a point where the outer segment of the rods and cones is actually sitting on the pigment epithelium. And finally, the outer reflective area is the RP-Bruch's membrane complex. So now in this picture also, if you see, there's actually no external limiting membrane. There's in this area, if you're not able to find external limiting membrane, and therefore the visual prognosis will be poor for this patient. Similarly, we have the ellipsoid zone. Sometimes the reflectivity of the ellipsoid zone will decrease, or the ellipsoid zone will be lost, and that is also a poor prognostic biomarker. As you can see over here, this is the ellipsoid zone, and in this picture actually the external limiting membrane and the ellipsoid zone, actually both of them are lost. You can trace it till here, but then in this area they both are lost, and therefore the prognosis will be bad. Then another biomarker is the presence of these hyperreflective dots and foci, okay, which are causing this back shadowing. So it is believed that they might be the degenerated photoreceptors or certain subclinical heart exudates that are not visible ophthalmoscopically. And the importance of hyperreflective foci is that their response to anti-VEGF is usually going to be very poor, and instead we need to supply them with corticosteroids, intravitreal corticosteroids. Then loss of parallelism. Now, we know that the retinal layers are present in layers formation, and all these layers are actually parallel to each other. And if because of edema, what happens is these layers are going to lose their parallel arrangement, and that will lead to poor response to treatment. Now, Another biomarker is outer retinal tubulation. What happens is that when the photoreceptors are getting degenerated, they will now arrange themselves in a circular or tubular fashion. Okay, and ORT is actually not a very common feature of diabetic retinopathy. It is usually seen in age-related macular degeneration and various other chronic degenerative retinal disorders. However, if you see them in diabetic retinopathy, it is a sign of poor response to treatment. So similarly, you can see here, this is an ORT, this is an ORT, and all these are ORT. They are nothing but degenerated photoreceptors arranging in the form of tubules. Then we have the choroidal thickness. Now, usually in diabetic retinopathy, what we see is the thinning of the choroid. Okay, choroidal thinning is basically seen. Now, what happens is that the thickness of choroid can actually serve as a predictor of the outcome in a patient. If a patient has a thicker choroid, what does it mean? It means that his choroid capillaries will be good, and as we know that the retina is supplied from the outer retina is supplied from the choroid through the vessels which are present in the choroid. So if someone has a thicker choroid, the outer retina will be taken care of from the choroid for its blood supply and for its nutrition, and therefore the outer retinal ischemia will be less, the preservation of photoreceptor will be more, and the patient will have better visual acuity. So this is how the choroidal thickness is going to act as a biomarker. Then we can also do an OCT angiography, and we can study the deep capillary plexus and superficial capillary plexus and what is the density of these plexus. So whenever we have a poor vessel density, it basically indicates that the response to VEGF will also be poor. So in this picture, you can see the deep and the superficial capillary plexus. You can see the deeper ones are actually present in the inner nuclear layer, and these you have the superficial ones which are present more superficially. So OCTA will actually tell you about this deep and inner vascular plexus in detail, and whenever the density of these vessels is decreased, they will have poor response to the anti-VEGF. So this was about the biomarkers, the patterns, and the importance of OCT as an ancillary treatment in diabetic retinopathy. I hope this video brought some value to your knowledge, and if it did, kindly share the knowledge and like and subscribe. Thank you and have a nice day.